Thank you. It's my pleasure to be here and to talk to you today. Haven't seen a lot of activity here in the way of bringing multiple disciplines together to talk about sarcoidosis, and I'm so pleased to see this happen. So my goals for you today are to introduce you to the kinds of problems that can occur with involvement of the nervous system by sarcoidosis, and to introduce you to approaches to treating neurosarcoidosis. I'm going to start by telling you about 4 patients under my care. One or more of these people could even be in the room today. The first one is an African-American woman in her early 30s. And let me start right there by just commenting about my use of African-American in describing this patient. When I tell people about patients in general, and I think most physicians don't refer to their ethnicity unless there's a particular reason that's relevant. When one is considering the diagnosis of sarcoidosis, I think it's always relevant because their ethnicity has such a strong influence on whether this is the correct diagnosis for them. In 2008 and 2009, this woman had abdominal pain. She lost 40 pounds of weight. She had night sweats. The CT scan of her abdomen showed a large spleen, large lymph glands in her abdomen. She had a needle biopsy done from one of those lymph glands in her abdomen that supported a diagnosis of sarcoidosis. She was treated for periods of time with prednisone, and her condition had some relapses during that time. In 2013, she was referred to my clinic because of headaches, nausea, and an abnormal MRI. We treated her with prednisone, Cellcept, and 2 infusions of Remicade. So when I see bad neurosarcoidosis, I bring to bear on it 3 treatments, and those are the 3: steroid treatment, Cellcept, which is an example of an immunosuppressive medication, and Remicade, which is an intravenous medication, also with immunosuppressive characteristics. But after a brief period of treatment lasting just a small number of months, she was lost to follow-up. The next year, in April of 2014, she was back with worsening again, severe headaches, nausea, vomiting. We again started the same treatments up because they had seemed to start being of benefit previously, and again her condition improved. I know you're not all used to looking at MRI scans of the brain, but we rely on them a lot for diagnosing this condition, and her scan is way abnormal. So these are like slices through the brain, as though the brain were a loaf of bread and you sliced it, and portrayed here are individual slices. On the outside are the skull and the scalp. Her nose, if it were evident at a lower level, would be at the top, and we're at a level a bit above her eyebrows here. And everything that's white toward the center of the image is abnormal here. On the surface of her brain in front, there are some deposits of sarcoid tissue that are like small pancakes. There are some balls about the size of marbles of sarcoid tissue. And you all know how the brain has these folds, and down in between the folds of the brain is abnormal sarcoid inflammation. So we treated her again in April of 2014. Her condition improved. She was again lost to follow-up. In May of 2016, she was again hospitalized with severe headaches, nausea, and vomiting. The same treatment, we started the same treatment. It had worked before. And we had her under treatment for 10 months with her condition improving a lot. And we last saw her in March of 2017. She's lost to us. Our phone calls have not succeeded in getting her back on track with the treatment. The big picture with this woman is that she's disabled by this illness. And even though when she's functioning pretty well, she comes across as a reasonably well-functioning person, she doesn't have the wherewithal on her own to stay on track with her treatment. She can't drive, she doesn't have a car. She's got family, but she's not able to marshal their help enough to keep her on track with her treatment. And I think it's probably just a matter of time before she's going to have worsening symptoms and be back in the hospital. Sad case, one of the worst that I've seen. This is a white woman in her upper 50s. From 2009 to 2013, her main symptom was worsening vision in her left eye. She saw eye doctor after eye doctor. She succeeded in pinpointing the problem at her left optic nerve. Ultimately, an MRI scan showed that she had swelling at her left optic nerve. And that was really the only point in her body where we could pinpoint the disease. She did develop other symptoms over that period of time: headaches, vertigo, dizziness, hearing loss in her left ear. Ultimately, we did a spinal tap which showed inflammation in her spinal fluid. At that point, we had the possibilities narrowed down to two likely diagnoses, one of which was sarcoidosis. She being a white woman, it wasn't as obvious that that was a strong contender as it might have been in an African American. The other was lymphoma. Normally what we do in that situation is do a biopsy, but if you ask an ophthalmologist, would you please biopsy the optic nerve? The eye doctors will say, sorry, we're in the business of saving vision. We're not going to take out somebody's optic nerve. So in 2014, I started her on treatment for sarcoidosis, not positive of the diagnosis, but thinking it was likely enough that it was worth seeing if that would help to get her disease under control. And it did. We started the same three medications, steroid initially, Cellcept. Over a period of time, she's had some relapses. At some point, we switched her Cellcept to Imuran, a different immunosuppressive medication. When she's had relapses, I think she's had 2 of them, we intensify her Remicade treatments, meaning we do them more often. And she's had a total of 23 of these infusions of Remicade since about 2 years ago. Somewhere in there, in October of 2015, we were able to prove the diagnosis of sarcoidosis in her lungs. It caused no symptoms in her lungs, but she had a bronchoscopy which was able to get tissue, the granulomas that the doctor talked about earlier, supporting the diagnosis of sarcoidosis. Today she's clinically well, except for a symptom of pretty much blindness in her left eye. I think she's stuck with that forever, but she's living a good life. She's working full time. African American man in his early 50s. In May of 2016, he was hospitalized with abdominal pain, loss of appetite, 60-pound weight loss. Part of the story is like an earlier patient. CT scans showed large lymph nodes in the chest and abdomen. A biopsy from his lung and from a lymph node in the chest confirmed the diagnosis of sarcoidosis. In July of 2016, he had facial paralysis on his right side, and that's involving cranial nerve 7. And that's a common problem in sarcoidosis. There's a diagram here showing the brain from the bottom side, and there are a series of 12 nerves on each side that come out from the bottom of the brain. And the inflammation in the nervous system is often predominant around the bottom of the brain, and those 12 nerves are a favorite site for sarcoidosis to cause symptoms. So the 7th nerve is right there. That was the offending site in this case for that right facial paralysis. And in October of 2016, he had worsening with loss of his voice, but loss of swallowing in particular, severe enough that he needed to have a feeding tube placed for a period of time. And we got him on treatment with prednisone and Cellcept. That's when I became his doctor, and I felt that we could go with just 2 of those 3 modes of treatment, holding off on the Remicade. And his condition improved. The feeding tube was able to get removed, and he returned to being a fairly well person. However, in January of 2017, he had a stroke causing partial paralysis of his left side. That stroke was involving the brainstem, somewhere close to my fingers. It's a fairly unusual place for strokes to happen, and when we know that there's a stroke in that area, there's a bit more chance of less common causes of stroke as opposed to just hardening of the arteries. We also know that this man was relatively young for having a stroke and didn't have as much of the usual risk factors as we might expect for him to have a stroke. We did a spinal tap which showed quite a bit of inflammation in the spinal fluid. And I took that to be evidence that the stroke was probably caused by blood vessel inflammation in the brain. With that, we geared up his treatment further, adding Remicade, switching from Cellcept to methotrexate, and we're continuing those treatments. And he's doing well with his only mild disability being residual effects of that stroke. Fourth patient is an African-American man in his early 30s. In 2012, he had a seizure and was started on anti-seizure medication. He lost 60 pounds of weight over the ensuing months, developed weakness in both legs, and had sarcoidosis diagnosed by bronchoscopy. He was started on steroid, the same three medications, steroid, Cellcept, and Remicade, and his condition improved in most respects, but he has continued to need a wheelchair for his mobility. On his MRI scans, this is at the level of the eyeballs, as you can see, and this is the brainstem here. And if the whiteness on the outside of the brainstem is abnormal, these are deposits of sarcoid granulomas. This is one of the nerves coming out of the brainstem. Looks different on this side than it does on this side. This nerve is involved by sarcoid inflammation. There's also sarcoid inflammation on internal surfaces of the brain. This is his upper spinal cord at the level of the neck. If it went up higher, we'd see his nose on the left side of the image pointing that way. And this is his spinal cord. And on the surface of his spinal cord, we can see white layers of abnormal sarcoid tissue. So in 2014, he had additional seizures. We repeated an MRI which showed that there was worsening of the sarcoidosis in his brain. We again started him on steroid medication, intensified the Remicade regimen. I think we had stopped it and we restarted it at that point. He's had additional minor episodes of worsening in 2016 and in 2017. So all four of these cases are among the more severe cases of neurosarcoidosis. People tend to have more severe neurosarcoidosis when they come to my clinic. All of them had diagnosis of sarcoidosis made elsewhere in their body with a presumption that we were seeing sarcoidosis in the nervous system. All of them have had some response to treatment, but have had relapses. And when they relapse, we re-intensify the treatment and get it back under control. The types of problems that can be caused in the nervous system by sarcoidosis, problems coming from the brain and the head can include headaches, problems with memory and thinking, weakness or paralysis on one side of the body, problems involving the nerves to the face, the eyes, and the ears, and I've shown examples of those, seizures, and hormone problems because the pituitary gland is at the bottom of the brain, in an area that is often involved by sarcoid inflammation. And the pituitary gland controls other glands in the body, the thyroid gland, the adrenal glands, the ovaries, the testes. And when the pituitary gland is malfunctioning, control of those glands is interrupted. When the spinal cord and spinal nerves are involved, there can be weakness or paralysis in both legs, or if it's high up, in both legs and both arms. There can be loss of sensation in the lower body. And skip that, there can be partial or complete loss of bowel or bladder control. Sarcoidosis can also involve the nerves that go to the arms and legs and can involve the muscles. Those would also be considered examples of neurosarcoidosis. I tend not to see that, and I believe that to be less common. It can be hard to diagnose. We suspect neurosarcoidosis when a person has symptoms of a neurological problem, and then beyond that they have, let's say, a neurological problem that gets us thinking about neurosarcoidosis. That's a stumbling block right there, because doctors are not always quick to think about sarcoidosis involving the nervous system. They, of course, should be quick to think about it when they're dealing with a person who's known to already have sarcoidosis. They should be perhaps a little bit quicker to think about it in a person of African American heritage. But when we're seeing somebody with a neurological problem and thinking about the problem, we look for either of two other things to further support the diagnosis of sarcoidosis. One would be typical abnormalities on MRI of the brain and the spine, and I've shown you examples of that. And the other would be evidence of inflammation in the spinal fluid from spinal taps. And I think three of the patients I already presented had examples of abnormal inflammation in the spinal fluid. When we diagnose neurosarcoidosis, we can use either of three terms to describe our diagnosis. Possible neurosarcoidosis is the diagnosis when somebody has a typical neurological problem and we believe that it's due to sarcoidosis, but we don't have proof from either the nervous system or anywhere else in the body that they have sarcoidosis. The case of the white woman with the left eye problem had possible neurosarcoidosis for a good part of the time that I treated her. Probable neurosarcoidosis is somebody who has a typical neurological problem and they have a biopsy from elsewhere in their body showing sarcoid tissue. That's the most common situation in my experience in people with sarcoidosis of the nervous system. Definite neurosarcoidosis is a term we use only if somebody has a typical neurological problem and they have proof of sarcoid granulomas from the nervous system. That would require a biopsy, most commonly from the brain, most commonly from other parts of the nervous system. Those are not done very commonly. Treatment of neurosarcoidosis. The kinds of treatments we can use are the same as the treatments we can use for sarcoidosis elsewhere in the body. At the top of the list is steroid treatment, and that's at the top especially because it's usually the first thing that's done. It's very easy to start up on the day that you see somebody, and steroid treatment, the most common steroid that's used is prednisone, and in severe cases we may give a different steroid by vein for 1 to 5 days to get a jump start on the steroid treatment. The role of the steroid treatment is to get the sarcoidosis under control, and usually it's taken for 1 to 3 months. I already got a sense that some people here know a lot about steroid side effects, and you can imagine that it's disadvantageous to use steroids as the main treatment going on for many months or years. Immunosuppressive medications taken by mouth include Cellcept, methotrexate, and there's several others that can be used. And I think of their role as being to help keep the sarcoidosis under control. They don't act as quickly or as surely as the steroid medications, but they can help keep the sarcoidosis under control. They can probably help to reduce the need for using steroid medication. Remicade given by vein is, I think, I don't want to say it's the treatment of last resort. It's the strongest treatment that we will go to because, among other things, it has important risks to it. And it, in my experience, is highly effective against sarcoidosis, at least in helping to get and keep the sarcoidosis under control. And it will sometimes start out by giving it as often as every couple of weeks. After a couple weeks or months, we're usually giving it no more than every month or two. And as we approach a year, we're usually giving it no more often than every several months. And the usual duration of treatment in my hands is between 1 and 2 years. Briefly talking about side effects, I've listed steroid side effects here, and I'm not going to run through those, partly because many of you already know about those things. And also, some of the main side effects are listed there. The immunosuppressive medications have a risk of abnormal infections, things that you wouldn't normally be susceptible to. The risk of these infections is quite low, but that is an important risk. And some of these medications also have a very small risk, especially after many years, of emergence of lymphoma as a cancerous diagnosis in the body. Remedies can cause reactions during IV infusion. They're not usually severe, and most people get no reaction. Remicade also increases the risk of getting abnormal infections to which you otherwise wouldn't be susceptible to. It can have effects on the kidneys. Challenges in sarcoidosis and neurosarcoidosis. Getting a better understanding of its cause. Understanding why it has a predominance in certain ethnic groups, especially those of African ancestry. If we knew this, to me, this is a big hole in our diagnosis of sarcoidosis. And if we knew this, of course, we could better serve African American people. But this has to be a big clue as to what's causing sarcoidosis. And thus far, I don't think we have a grasp on this. Why, in some patients, does it stay in the lymph glands? In other patients, go to the lungs. And in fairly unusual patients, about 5% of all patients with sarcoidosis go to the nervous system. And of course, we need better treatments. So I want to thank the Foundation for Sarcoidosis Research for not only for inviting me here, but for having this excellent get-together today. I want to thank the team who works with me taking care of patients. And I want to thank my patients for helping to teach me about sarcoidosis and give the opportunity to participate in their care. Thank you.